Welcome back everyone. Today's lesson is about neuroblastoma. Neuroblastomas are embryonal cancers of the peripheral sympathetic nervous system, and it is the most common extracranial solid tumors in children and is the most commonly diagnosed malignancy during infancy, and it accounts for 8 to 10% of childhood malignancy and 1/3 of cancers in infants. Neuroblastoma accounts for 50% of the mortality from cancers in childhood. And the median age of children at diagnosis of neuroblastoma is 22 months, and 90% of cases are diagnosed by 5 years of age. The incidence is slightly higher in boys than girls. When we see the pathology of neuroblastoma tumors, which are derived from primordial neural crest cells, form a spectrum with variable degrees of neural differentiation. The tumors might resemble other small round blue cell tumors such as rhabdomyosarcoma, Ewing's sarcoma, non-Hodgkin's lymphoma. The prognosis of children with neuroblastoma varies with the histologic features of the tumor as dictated by the presence and the amounts of Schwannian stroma, the degree of tumor cell differentiation, and the mitosis index. Regarding pathogenesis, the etiology of neuroblastoma in most cases remains unknown, and familial neuroblastoma accounts for 1 to 2% of all cases, and it's associated with a younger age at diagnosis. Neuroblastoma is associated with other neural crest disorders including Hirschsprung's disease or aganglionic megacolon, central hypoventilation syndrome, neurofibromatosis type 1, and potentially congenital cardiovascular malformations. Children with Beckwith-Wiedemann syndrome and hemihypertrophy also have higher incidence of neuroblastoma. When we see the clinical manifestation of neuroblastoma may develop at any site of sympathetic nervous system tissue, and approximately half of neuroblastoma tumors arises in the adrenal glands, and most of the remainder originates in the paraspinal sympathetic ganglia. Metastatic spread, which is more common in children greater than 1 year old at diagnosis, occurs through local invasion or distant hematogenous or lymphatic routes. The most common site of metastasis are the regional or distant lymph nodes, long bones and the skull, bone marrow, liver, and the skin. And lung and brain metastases are rare, and it is responsible for less than 3% of cases. The signs and the symptoms of neuroblastoma reflect the tumor site and the extent of disease, and it might mimic other disorders, which can result in a delayed diagnosis. Metastatic disease can cause a variety of signs and symptoms, including fever, irritability, failure to thrive, bone pain, cytopenias, bluish subcutaneous nodules, orbital proptosis, and periorbital ecchymosis due to infiltration of periorbital fat tumors. Localized disease can manifest as asymptomatic mass or can cause symptoms from mass effects, which in certain cases can result in spinal cord compression, bone obstruction, and superior vena cava syndrome. Children with neuroblastoma can also present with associated neurologic signs and symptoms. The neuroblastoma originates in the superior cervical ganglion, can result in Horner syndrome. And paraspinal neuroblastoma tumors can invade the neural foramina, causing spinal cord and nerve root compression. Some tumors produce catecholamines that can cause increased sweating and hypertension, and some might release vasoactive intestinal peptides, causing a profound secretory diarrhea. Children with extensive tumors can also experience TLS and DIC. Infants less than 18 months old can present with unique fashion termed as stage MS, with widespread subcutaneous tumor nodules, massive liver involvement, limited bone marrow disease, and a small primary tumor without bone involvement or other metastasis. The stage MS, which is previously known as stage 4S, it can spontaneously regress. When we see diagnosis of neuroblastoma is usually discovered as a mass or multiple masses on plain radiograph and CT or MRI. The mass often contains calcification and hemorrhage that can allow it to be appreciated on plain radiograph or CT scan. Tumor markers, including the catecholamine metabolites, such as homovanillic acid and vanillic mandelic acid, are elevated in the urine of approximately 95% of patients, and they can help to confirm the diagnosis. A pathologic diagnosis is established from tumor tissue obtained by biopsy. Neuroblastoma can be confirmed without a primary tumor biopsy if small round blue tumor cells are observed in bone marrow samples and vanillic acid and homovanillic acid levels are elevated in the urine. Evaluations for metastatic disease should include CT or MRI of the chest and abdomen, bone scans to detect cortical bone involvement, and at least 2 independent bone marrow aspirations and a biopsy to evaluate for marrow disease. MRI of the spine should be performed in cases with suspected or potential spinal cord compression, but imaging of the brain with either CT or MRI is not routinely performed unless dictated by the clinical presentation. So, overall, neuroblastoma can be easily diagnosed by increased in vanillic acid and homovanillic acid levels in the urine with bone marrow samples that shows small round blue cell tumors. The International Neuroblastoma Risk Group staging system is used to stage patients with neuroblastoma and is based on the extent of the disease as determined by imaging at diagnosis. Extent of local regional disease is based on specific local image-defined risk factors. L1 tumors are localized and confined to one body compartment without any image-defined risk factors, whereas L2 tumors refer to localized tumors with the presence of image-defined risk factors. Disseminated tumors with metastasis to bones, bone marrow, liver, distant lymph nodes, and other organs are staged as M stage. Stage MS refers to neuroblastoma in children less than 18 months old with dissemination to liver, skin, bone marrow, without bone involvement and with a primary tumor that would otherwise be staged as L1 or L2. Just to see the highlight of the treatment of neuroblastoma. Treatment for children with a low-risk neuroblastoma typically includes surgery for stage L1 and L2 and observation for asymptomatic stage MS with cure rates generally greater than 90% without further therapy. Treatment with chemotherapy or radiation for the rare child with local recurrency can still be curative. Children with spinal cord compression at diagnosis might require urgent treatment with chemotherapy, surgery, or radiation to avoid neurologic damage. Stage MS neuroblastoma or neuroblastoma that occurs in those less than 18 months have a very favorable prognosis and many regress spontaneously without therapy. Treatment of intermediate risk neuroblastoma includes surgery, chemotherapy, and in some cases radiation therapy. The chemotherapy usually includes moderate dose of cisplatin or carboplatin, cyclophosphamide, etoposide, and doxorubicin given over several months. Radiation therapy is used for tumors with incomplete response to chemotherapy. Children with high-risk neuroblastoma historically have had poor long-term survival rates between 25 and 35 with treatment that consists of intensive chemotherapy, autologous stem cell rescue, surgery, radiation, and vitamin A derivatives. This is all what I have for neuroblastoma. Thanks for watching.